Well, a clinical trial has to have, I don't think influences at all, but when you do a clinical trial across multiple centers, even one center, you have to have defined criteria for who can go in the study. So these criteria are good as any, uh, and you have to have criteria for who you're going to define in a disease category. So again, that's another use for these criteria, which I think are very useful. And again, it's a lot of this technology based. So the kappa-free light chains have been around for quite a while. I mean, over decades. But the finding that it's about as good as oligoclonal bands and much easier to do, much faster to do, and replacing that as a criteria, I think is a very good idea. Again, based on technology and the paramagnetic rim lesions, which have been added, and a great deal of specificity to the diagnosis. And again, relatively new finding. What it means clinically isn't quite clear to many of us yet, but still very much associated with MS. So again, technology-driven findings lead to a higher probability of making a diagnosis. But I think we need to look at the criteria in a probabilistic way, which I don't think is really done, and just say that increases the probability that pathologically that this will fit into the group of patients that we call MS. Well, I guess my closing remarks would be that if the early treatment is critical, and B cell depletion, whatever form of be it subcutaneous, intravenous, is, I think, a paradigm shift in the field of neurology. And it turns out, in particularly younger individuals, to be a very benign form of therapy. And I think it's absolutely critical to initiate treatment as early as possible. I think another question is really what comes next. So we move from something called CIS, clinically isolated syndrome, which I've always rejected as an idea. I mean, it doesn't make sense to me. I call it singular sclerosis, which is probably as meaningless as CIS, but the idea it's the first attack. RIS, I think, is a big step forward for the field, finally acknowledging that just because someone hasn't had a clinical attack, if you have inflammation in your central nervous system and clear lesions MRI, it's MS. We know that for every one clinical event, there are 10 MRI events. So why would you need to have a clinical event to get to the pathologic diagnosis? And for years, we've been treating RIS, though we want to see inflammation in the spinal fluid with B cell depleting therapies. I think that the question is, what's the next step? And I think the next step, what we really want to do, I want to do, is to be able to diagnose MS before their parenchymal lesions. And the question is, how do we do that? And I don't know how, but we're beginning to examine studies that we might be able to do by taking patients who are first-degree relative, young women, who have genetically have a higher predisposition because they're women, who have a first-degree relative with MS and have a high polygenetic risk score. Those individuals have a very real chance of developing MS, and particularly take individuals who have not been exposed to Epstein-Barr virus, EBV, yet, and to follow them serially with the blood draws, looking for increases in nerve fibrillary light chains, which indicate central nervous system damage. And then we have serial blood draws before there was disease. And then be able to go back and say, what are the parameters that change, which are highly predictive of actually developing parenchymal disease? Perhaps autoreactivity to myelin antigens by T cells, which can now be easily measured with MHC class II tetramers. So I think that's the really next big step, which will give us insight into the biology of the disease and insight into the pathogenesis.